Good morning, good afternoon, good evening, wherever you are. It's a great pleasure for me to kick off this second webinar that we are organizing it from PQE. And we want to present to you today another scope of our intervention about the FemTech revolution. And that's why we joined forces, the PQE Group and the FOGSI, stands for Federation of Obstetric Gynecology of the Societies of India. I would say the second biggest federation globally. So we'll try to present to you what we think is the FemTech revolution with regard mainly to perinatal medicine. And we'll present our production by reshaping and digitalizing women's health, bringing innovations to implementation. I sometimes call it even a bit differently, connecting the bench to the clinical practice. And we'll divide today's presentation into two parts, and I'll present it right away. I would like to present my co-chairman, my co-moderator, Dr. Hema Divakar from Bangalore, and both of us will be conducting this, I would say, outstanding webinar. The purpose is to connect the FemTech community, mainly, entrepreneurs, venture capital investors, to the medical community as doctors, scientists, and to bring them together, because right now we are still separated. So welcome to this outstanding webinar, and Hema Divakar, dear Hema, or Hema Ji, please take it over now.
Thank you, Moshe. Namaskar. I bring you greetings from 1.4 billion Indians and 40,000 OBGYNs on roll of our national professional organization, FOGSI, which is jointly with PQE hosting today's webinar. Ladies and gentlemen, you'll all agree with me that the convergence of technology and women's healthcare has opened up unprecedented opportunities. We will see how technology is revolutionizing the women's healthcare in India and making significant impact of reaching the unreached. Before we begin the formal presentations, I hand over back to Professor Hood to introduce and invite the FIGO leadership to make her opening remarks. Professor Hood, please.
Thank you, Hema. It's three of us, and I'm very glad to join forces with the two leading ladies in women's health. One is Dr. Anne Beatrice Kihara from Kenya, and in 2 weeks, you'll have to address her differently. She is going to be, in 2 weeks, the president, not the president-elect, but the president of FIGO. So in 2 weeks, I would say the world is going to change. We'll hear more and more about LMIC, low and middle income countries, and how do we implement these new technologies, these innovations, startups, whatever we can do in order to give a hand to LMIC. And I don't think there is any better candidate, ambassador, than Anne Kihara. Anne, it's a great pleasure for me to have you on board. The floor is yours.
Thank you very much, Professor Moshe. I'm really glad to be here and really speaking technology. But I want to give us some context. What are the challenges, particularly for LMICs, that we are facing? Number one is having the enabling environment in terms of political goodwill, socioeconomic status, adaptation to technologies, both digital and even FemTech technologies, the issue around ethics, culture, the divergence of people that we have to address, social inclusivity and equity. A patient-centric approach is really where we all need to be moving to, with primary health coverage and universal health coverage. But my question is, as we move to individualized, predictive, and precise care, are we having adequate health literacy amongst this populace? And therefore creating patient social behavioral change that even pushes them towards self-care. Do we have the policies, guidelines, access, training in self-care technologies? the setting up of innovative multi-sector hubs locally. When I say locally, it's in LMICs. Funding resources. Do we depend still on external sources, or should we really be investing in domesticated environment for technologies? The other thing that is critical as we speak about these technologies is the aspect of having finances dedicated, ring-fenced to the issue of technologies. Moving on, are we developing technologies that are fit for purpose and therefore implementable? What are the regulations and clearances needed in countries? Mass production, is it going to happen externally or internally? And therefore speaks to our communication and marketing strategy for sustainable scaling and market diffusion. Data management. Those of you online, please note, a lot of LMIC countries are still using manual databases. We need to also be moved along the chain to have real-time capture of data to make informed decisions. And finally, the advocacy arm, demand generation for these products and continuously have R&D being undertaken. This is where I believe FIGO comes in with the member societies that cover 139 societies scattered globally and including low middle income countries. We need to wake up, shake up, join up with academia and researchers and the learning hubs that do exist and those that are in for creation in addressing curriculum development, capacity building on innovative programs with a life course approach. And finally, ladies and gentlemen, we all need technology in the palms of our hands. This is the drive to rights and autonomy and self-advocacy. Back to you, Moshe.
Yeah, thank you so much, Annie. And I think you have covered a whole 360-degree round perspective of what we can join hands together to walk the talk. And I know that you are a great believer in action and innovations waiting to be implemented, especially in our part of the globe. We do hope that it will be a reality in your position of leadership as the president of FIGO. So thank you very, very much. It is indeed our proud privilege next to present to you, dear friends, Dr. Rishikesh D. Pai, who is at the helm of affairs with one of the largest organizations of more than 40,000 specialists, as I have told. He is currently the president of FOGSI, which is our national parent professional organization. He's also the CEO of the Bloom IVF Group, and he is a professor of reproductive medicine at the D.Y. Patil Medical College. Maybe have some opening remarks by the FOGSI leadership, please. Dr. Pai.
Hi, everybody. Hema, can you hear me?
Yes.
I'd like to pay my respects to Professor Moshe Hord and Professor Ann Chiara and Hema Divakar and all of you here. And would like to thank PQE for arranging this wonderful event. And as you know, FOGSI has been organization of nearly 40,000. Now we have crossed 40,000. We are 41,000 members now with 270 societies. We cater to the large population of India, which is one of the highest in the world, 1.42 billion. And of that, nearly 680 million are women. And, FemTech, of course, the word was coined by Ida 10 in 2016. And, because I'm a lot into IVF, there's huge amount of explosion in IVF space. But, if you look at the overall explosion, you have digital marketing, which is very important now. We need the marketing to access the population. We need counseling services. So we have telemedicine, which has been developed well. The government has actually, the National Medical Council has just come out with a new regulation, but which was withdrawn for some issues. But it has got a massive amount, nearly 30 pages of telemedicine, how to consult, what are the regulations, how to do payment. So telemedicine is becoming a huge thing, and the government has accepted it as a way of consultation. You can do billing as well. You have got a lot of services connecting patients to doctors. You have got apps which are related to menstrual cycles, fertility prediction, ovulation and pregnancy tracking. We have wearable devices like temperature, respiratory, heart rate, fertility monitors. EMR systems have become very big now, a lot of but there's so many systems available. It's a bit confusing as to which system to develop, and a lot of them will come with artificial intelligence. We have cervical, there's a company which is already doing cervical examination. You can just take a photograph of the cervix and it goes and it tells you whether this has a high chance of cancer, and it's really percolated well into the population. Of course, in surgery, 3D ultrasound, 4D ultrasound, big data, already technology is there. And in other things, like I've just now got a call from a IIT group in Mumbai saying that, sir, you can do a wearable, and if the patient is doing IVF, if they are under mental stress, it can be picked up and we can do counseling services. So it's so there are a lot of contraception, pregnancy care, artificial intelligence, especially in IVF, antenatal care, oncology and genetics. We have a lot of next-gen sequencing labs now in India. After COVID, there's a huge amount of genetic explosion, literally. And in NGS also, you can use artificial intelligence. And then if you look at the federation, we are in a early nascent phase. We have done the website. We are now doing app. We have digital media, online election. All our elections are now online. We do online surveys. We have a Manyata program for upgrading nursing homes. So before COVID, we used to actually visit. Now we don't do it by visit, we do it online. So online grading, HEMA is a part of the Manyata program. And last 1,000 centers we have done online grading. So this can be taken as our leader, Dr. Anne Chiara, is interested in South. We can take it to Africa. We can take it to Asia. We have a new app for a labor room, which is being integrated by the government. It's called a Mantra app, which is being backward integrated. It's funded by the UNICEF. And then, so what are the areas which I feel in the future, there are 5-6 areas, just I'll enumerate, I don't want to take your time, but telemedicine integration for maternal and reproductive health will be a new future for us. Mobile apps for patient education and tracking, and using artificial intelligence, we can actually, in our waiting areas, we can use the robot, and we can, before the patient goes into the doctor's consulting, it can interview and it can also counsel patient about other parallel services. Patient has come for one area, but you can counsel them for other areas of service as well. We can have digital platforms for sharing medical guidelines. E-prescription is going to be the future for most of us. Virtual support groups for women with health concerns, remote monitoring of high-risk pregnancies. We have the
Thank you, Rishikesh. I think it's quite clear. So we have to move forward.
Okay. So FOGSI, and the last thing is we have just launched 2 days back an online platform for patient education and for doctor education by the Federation. So thank you, Dr. Moshe, for inviting me here, and we are looking forward to a very good interaction.
Excellent. Thank you very much, Rishikesh. And we count on FOGSI. You are the largest association globally. India has over 30 million deliveries per year. It's unheard of. Whenever the continents, Europe and the United States, have about 4 million deliveries per year. So how do you compare it to 30 million deliveries in India? So the market has to be shifted to low and middle income countries. Africa with 30 million deliveries, India with 30 million deliveries. It's half of the global deliveries, which is about 130 million deliveries. So thank you very much, Rishikesh. We appreciate very much the collaboration with FOGSI, and we'll continue to work hand in hand. Now it's my great privilege to present the next speaker, and it will be Stephen Tirpak from the United States. Stephen belongs to the PQE Group. He is the Associate VP of Medical Devices Operation in the United States. And Stephen is I would say, a global expert on FDA and its regulation. Stephen, welcome aboard.
Thank you, Professor. So to know where we're going, I think it's always important to remember where we started. So when we look at the history of FemTech, in 1986 is when women were considered to be part of clinical trials. When we look at the birth of FemTech, it really wasn't until 2016. That's too recent. When we look at the actual boom and when FemTech became the leader globally as the fastest growing industry. That was 2018. That's very, very recent. So when you look at the growth, things that we've done right, because my focus has always been not just bringing low income countries technology and innovation, it's bringing them safe innovation. So the things that we're doing right is starting to take into account that biology and environment play an impact on FemTech. Women, more so than men, are impacted by hormonal changes, are impacted by birth rates, are impacted by their environment in ways that up until 2016 really were not focused in clinical research. That led to poor adverse events, specifically in low-income countries. But another good thing that's happening is globally, finances and resources are being put into this field. When we look at what's ahead for us, these are conversations that may sound like problem statements, but conversations like this are happening globally, and these are going to be resolved. But unfortunately, it takes a global community to fix them. We look at the fact that FemTech is so young. One of the issues is that research is just not caught up to it yet. When we look at the aspect that we still don't understand how menstrual cycles impact psychotics and how the impact of the menstrual cycle can actually adversely affect medication that's just not studied. When we look at the fact that high income countries are still very early on in their FemTech research, things like AI integration into diagnosing of breast cancer, these are all things that are still early on, and research suggests that low-income countries won't have these technologies for 5 to 10 years after they're available in the US. That's unacceptable. When we look at the high-income countries' regulatory pathways for innovation, or specifically around FemTech, they haven't caught up to the innovation speed yet. There are not pathways, there are not innovative systems put in place yet that are going to allow these devices to get to market at a reasonable speed. Looking at the global community, high-income countries do not focus on low-income country populations for their clinical research yet. Because of this, most countries who want to be launched in the US, most companies, they focus specifically on US populations. That means that the low-income countries are receiving products that may never have been tested there. They're receiving products that may have an underpopulated study to show the safety. This is also resulting in unpredicted adverse events. These are the things that need to change, because my goal and the global community's goal is to bring safe and effective treatments to these low-income countries. To do that, though, it's going to take the global network to understand that we need to start taking ethics into medicine again. We have to start understanding that every person deserves healthcare, and that can't just be driven by finances. And that brings us to the next problem, is that there's typically a lower return on investment for innovation in low-income countries. This is unacceptable. We cannot be driving healthcare based off of finances. The biggest issue on this list here is that countries lack proper communication between researchers, industry, academia, regulators, and reimbursement. Products might get to market, but if they can't be distributed and reimbursed, they're not actually in the hands of the patients that need them. These are all the conversations that are happening globally, but these are the areas that we need support on. These are the areas that regulators have to step up and say, what can we do to help you? I look forward to the rest of the talks today from my industry partners, and thank you for having me, Professor.
Thank you very much, Steve. It's very enlightening, and that's exactly where we point. And that's exactly, I think, the role that the next president of FIGO is going to take. She is coming from low and middle income countries. So she has 2 years now to push this agenda forward. It will happen. I don't have any doubt. And that's why we address the issue today of perinatal medicine, mainly devices, medical devices related to pregnancy management. But as Rishikesh introduced us, we'll deal with reproduction, with oncology, with menopause. Everything is there. So today, we are in perinatal medicine. Now it's my great pleasure to hand over the moderation to my dear friend Hema Divakar, and she'll take us over for the next 3 presentations from India. Hema?
Thank you, Moshe. The humans, the girls and the women are at the center of this entire revolution. So what is it that it takes to design, think about the complex medical challenges? Innovation is out there, but would it work in the context that we are putting it out for the society to utilize it? So the design thinker is none other than Dr. Bhaskar Bhatt. He is the director of the School of Design, Anant National University in India, and he is the founder of MedicSyncs LLP, the design for healthcare consulting. May I present to you Dr. Bhaskar Bhatt.
Thank you, Dr. Devakar. It's an absolute pleasure to be amongst such doyens and esteemed colleagues. Please give me a moment. I'm going to pull up my slides. If you could just give me a moment, please.
I think they're sharing your slides, Bhaskar.
Yeah, is that visible?
Yes.
Wonderful. So over the next 5 minutes, I shall showcase an interesting project in the maternal health space that we have done. And the project that we called Saving Lives by Design, wherein we were looking at using design thinking as an approach to come up with some frugal solutions for LMIC. Now, the prelude to this was the Saving Lives at Birth Fund that grant that Johns Hopkins won many, many years ago. And we were design thinking partners or systems thinking partners. And they simply asked us, they gave us a brief. It said, could you explore design thinking as an approach to look for frugal and sustainable solutions for maternal mortality? And that's how the project began. Now, typically in the world of design thinking, which most of us are familiar with, there are 5 very clear steps which talk about empathize, define the idea, ideate on the idea, prototype continuously, and test. I mean, this is very well known across the world. So what we did was we moved away from that paradigm and we built a slightly different paradigm, which I would like to speak about today. So the first part of that project was to really understand the contextual understanding, or really the question that we ask is, what is to be known? And these include field visits to hospitals, to corporates, and to other institutions of repute in the country to understand what maternal mortality was all about. And the second, and probably the most important aspect of the design thinking or systems modeling paradigm is to really listen to the users from the front lines. I think this is what Dr. Ann Kihara also said last time. She said, listen, that's the most important thing. And that's what I would like to really stress at. These are images from the field, which we conducted across multiple locations in India, Nepal, Kenya, and Uganda as well. I don't have the images from Uganda here or Kenya here, but these are images from India. This includes a very interesting paradigm called listening to learn. In other words, how do we really ask the right questions? How do we keep our eyes and ears open, and so on and so forth? And you'll see a lot of information that was collected over here. Now, this slide over here talks about how do you take that enormous amount of information that we've collected over 8 months, and how do you build those relationships? Because at the end of the day, an issue like maternal mortality or maternal care is not a straight line problem. It's not something that you can solve in a jiffy. It requires complex modeling. And the methodology that we adopted was what was known as systems modeling, which even the World Health Organization has propounded strongly in a paper in 2009. Now, this really talks about measurement and mapping of all the stakeholders and how different people have different relationships to play. So using that methodology, I know that I have only 5 minutes to explain a year's long worth of work, but using that methodology of systems modeling, this is the entire systems model of the unholy trio of maternal mortality, PPH, and anemia mapped in the Indian context of things. You realize that this has stakeholder mapping of all sorts: the patients, the caregivers, the hospitals, the district hospitals, etc. And it maps not only physical issues or medicinal issues, it also maps emotional issues, it maps familial issues, it maps education, literacy, and so on and so forth. A few innovations that we came out, using the systems model, the last few slides over here, you take the complex model, but the ability to convert those complex understandings and relationships into simple, frugal and workable solutions is really, really important. So what you see over here as an answer to PPH is a portable battery-operated oxytocin transporter for deep rural connectivity in India. We know that oxytocin has to be preserved between 2 and 8 degrees centigrade. But when it comes to last mile connectivity, exposure to temperatures in India often cause degradation of the product. So this is a device that is battery operated that we built. And the next one over here is a proteinuria detector using the frugal design approach. This is the urine and acetic acid test. But we also know that in deep rural India, where electricity is a challenge, or rather complex substances are a challenge, we wanted to build a very simple frugal solution that allowed a frontline health worker to do a go or a no-go test. So this device detects the presence of proteinuria in the woman's urine. And the final innovation that we built out of that massive paradigm was a low-cost, non-smartphone powered anemia detector. Unfortunately, this did not do very well in clinical trials, but however, it was still a great start to see if we could actually detect maternal anemia and then get the woman help in time. Bringing my 5 minutes to a closure, all I wanted to say was that design thinking is a straight linear approach, but the complexity of challenges that exist in low-income countries or middle-income countries is actually based on a systems model. So using the systems model methodology, we were able to generate over 100 different opportunities for intervention, not just spread over products, but technology, services, policy, and human resource domains. So I will actually end my talk over here by just stressing the points that I said, that we should consider as a process systems modeling, which allows not only understanding from a pharmacological or a policy-based perspective, but it includes the voices of the women across the globe. We have to learn to listen, and the primary caregivers in the field, which allows us to build frugal, sustainable, yet effective solutions for maternal care. Thank you.
Moshe? Moshe, you're muted.
I just wanted to say thank you. Very enlightening. That's exactly where we want to move. And we need your collaboration, Bhaskar. So we'll continue working together with FOGSI, with PQE. That's exactly where we want to go. Hema, please. Now I think it's you. So I'll just introduce her in 2 words. Dr. Hema Divakar, for me, my Indian sister, is one of the Indian leaders of maternal fetal medicine, global women's health, and hopefully all 3 of us, Hema Divakar, Ann Kihara, and myself, will push forward the agenda of FemTech and women's health and perinatal medicine. Hema, the floor is yours.
Thank you so much, Moshe. You are the one who fueled the interest into the FemTech world, with the major conferences happening in your part of the world, where all the stakeholders came together and opened up our eyes into how much more and how much better we can do to deliver healthcare, especially in the LMICs. India's digital revolution, you will all agree, has catalyzed a wave of innovations which are transforming the women's healthcare. From the telemedicine platforms that Dr. Pai mentioned, to the mobile apps and the advancements which, when we tell the women, your health is in your hands, we literally mean it now, because it just takes a mobile technology for them to connect and do a lot of things inclusive of self-care and the issues of access and affordability. We are riding high on integration with technologies. So the medical expertise, the information, the services, without being constrained to the geographical distances or societal norms, are now a reality. So as you will see in the picture here, the doctor and the pregnant women both connecting with each other into the space of the catalyst called technology. Professor Moshe Hood and myself have been repeatedly toying with ideas. In fact, we've recently published an article about the FemTech revolution, because that is the only way we can see to leapfrog to make histories beyond the geographies. The telemedicine and virtual consultations, we ourselves have set up several e-clinics in the rural areas, where the health and wellness ambassadors, who are the community volunteers, strike a good rapport with the girls and women in the local region and connect to us through the mobile for the video consultation every single day. And there are a lot of FOGSI champions who have signed up as volunteers to offer their services so that the women in the last mile can have the best of the care. The mobile health apps have come in very, very handy. In many, many local languages in India, the apps help the women to empower themselves with the correctness of the knowledge and seek care and dispel their myths and misconceptions. And also it has been a very safe and confidential and anonymous space for them to interact with the healthcare providers. And as Dr. Pai said, Manyata Initiative, which is a flagship program of our federation, where we build the capacity of all the frontline healthcare providers and teams of the hospitals for certain protocol-based clinical initiatives. And how do we do that? Not by traveling 3 days to a week to a remote, far-to-reach destinations, but seamlessly, quickly, efficiently through the technology transfer for capacity building. This has been one of the major game changers because thousands and hundreds of hospitals with the teams have now been recognized as accredited centers delivering the best of the care. The remote monitoring devices. This is again a big dream that Professor Hood and myself have, as how many, many innovative and easy to use by any unskilled provider and also being cost effective are hopefully going to flood the LMIC market. As of now, there are menstrual trackers, ovulation trackers, and our patients with high blood pressure and high blood sugars, we ask them to key in their data on the Health for Her app, for example, so that the entire graph is available to us over weeks or days, and the remote fetal monitoring devices. The patient and the couple need not be anxious anymore if there's less fetal movements or they somehow feel that everything is not okay. We rent them out a FetoSense fetal device, which they have to just place on the abdomen, and the CTG gets on to the Bluetooth and reaches us as providers who give a thumbs up to tell them that all is well. Simple devices like this waiting to be enhanced right across the lifespan to do the best for the women. So ART, or the art of artist as we call, A for advocacy, R for research, which is implementation research, and T for training or capacity building. And already Anne has alluded to the big data, which can be obtained by the technology. And we do hope that we will make our investments going further in the right direction by recognizing the trends of what the girls and women need out there. Of course, there are challenges. There is a digital device. For example, in some remote parts of rural India, only men are privileged to carry the mobile device. And of course, when it's the health matter, they do lend it to their wives and their sisters to just have a short consultation. But mobile device, by and large, is a prized possession, almost with everybody in the country carrying a small Android device. The cultural sensitivity of how the messages to be conveyed to them is a challenge again. And the last two things I want to mention is about the data security and the data privacy. And above all, quality, quality, and quality. The quality assurance for training, the quality assurance for awareness, the right kind of messages going out there through the professional organizations. That's where we come in, and the misinformation trying to be avoided and a zero tolerance for the same. So with all of this engulfed in the FemTech 360, as we call it, right across the lifespan, as it has been the FIGO vision and the vision of our own president, Dr. Rishikesh Pai, who says integrating the healthcare at every touch point with the technology is the way forward. So not only we have leaped on to the moon, but we are making a big leap in the FemTech space, more to our girls and women. Watch this place as we move ahead. Thank you very much for this wonderful opportunity to strike base with the global leaders to help us do better by connecting and collaborating. Namaskar.
Thank you very much, Dr. Divakar. It's very, very clear. Now we'll move to the second part of our panel, and it will be a panel discussion on novel solution to pregnancy moving our agenda to home and point of care. We described a bit of it in the first part, but we'll have to move to the second part. And that's why we collected the best, I would say, in the industry indications and industry presentations to show us the case. It's only case showing. Then we'll move forward with the rest of it. I'll just set the scene for it with a publication that we just published about 3 months ago, and we were 4 on it, as you see. Hema Divakar, Anki Hara, and Michael Geary from Ireland, who is the editor of the International Journal of Obstetric and Gynecology. And that's a special article. It's an editorial. We called it the FemTech Revolution, a new approach to pregnancy management, digital transformation of maternity care, the hybrid e-health perinatal care clinic, addressing the unmet needs of low and middle income countries. So we are not going to play around. We want to move this agenda to LMIC. And the industry have to change a bit, had to adapt it. And the best person to describe it was Stephen Tirpak. He exactly defined that most of the industry is trying to reach the markets where they get the reimbursement, the payment, but the numbers are different. The numbers are in the low and middle income countries, 60 million deliveries between India and Africa, 135 million deliveries globally. And if you'll add to it the 8 Asian Pacific countries, then you will reach almost 80 million deliveries altogether. So 3/3 of the global population is there. So it's even more if you'll add some other low-income countries. So our commercial thinking, our business thinking has to change a bit. And we really hope to change it. So let me give you some examples, what we produced in this article, in this special article. Next, please. This is the evolution of perinatal medicine. Just one slide. I'm now presenting the traditional pregnancy management. And it's a kind of the 11th commandment coming from ACOG, the American College of Obstetrics and Gynecology, in the guidelines. It has a uniform prenatal visit schedule of approximately 14 visits. I'm not going to explain why and what. I just bring the evidence. Is there any evidence? No. It's based on tradition. So we are following ACOG. We are following the 11th commandment of ACOG based on tradition, not on evidence-based facts. And that's what we'll try to change. And we want to reduce this absurd number and very costly number of 14 visits. Next. And that's why we'll have to come to a new approach to pregnancy management, digital, the platform. And you already heard from Bhaskar and from many others, and you'll have now here from the industry presentations that the platform has to be a hybrid clinic. And you'll see a few examples here that I'm not going to waste any more time, but you'll see 5 show cases that will deal with it. How can we move our management from preconceptional through the first trimester, second and third trimester delivery, and that what we call now the fourth trimester. It's an innovation that we invented. The 4th trimester, it's post-conception. The post-conception is extremely important because we want to predict and prevent non-communicable disease in the post-conception, and that's the 4th trimester. And so now let's move to the cases. And the first speaker will be Sharat Bhaskar from GE Healthcare, and he'll present to you how can we move sonographic management that's till now is being performed in clinics, in medical centers. How can we move it forward to home and point of care? Bhaskar, the floor is yours.
Thank you so much, Professor
Sharat, sorry.
For giving me this opportunity to speak in this forum as well. So like you explained, my name is Sharat. I lead innovation and home care for GE Healthcare, for the women's health ultrasound business. You know, as leaders in development of healthcare technology, we constantly strive to be at the cutting edge of innovation. And we monitor these trends on a regular basis globally to see how healthcare delivery is changing and defined, at different periods of time. One thing what we notice is there is a shift of care setting from hospitals to clinics to home. There's an obvious movement because it's cheaper for the payers, it's more convenient for patients, and you can provide access to care which does not exist before. So we want to monitor this change. And the big shift happened during the coronavirus pandemic. If you look at GE Healthcare as a company, we have diagnostic ultrasound equipments where we are leaders, but it's geared towards a face-to-face care, which is what has happened over centuries. Now, during coronavirus pandemic, a lot of hospitals across the world try to provide simple devices like blood pressure cuffs, glucose monitoring devices, and they couple this with a phone call or a Zoom call to manage high-risk cases. And it worked extremely effectively. What we want to do is to transform this and set new standards of prenatal care by providing pregnant women with ultrasound devices in their hands. Now, we invested in a company about a year ago called Pulse & More, using which we have access to this technology, which allows an operator-dependent solution like ultrasound and makes it so simple that any woman can just take this device with no training and hover around 5 steps around their belly and have the images that can be reviewed by a physician, which clearly states, is there sufficient amniotic fluid? Is the baby moving? Is the heart beating? And this is sufficient for them to reduce anxiety. Because as you know, if there's a pregnant woman, especially nowadays that the ages of pregnant women are rising, pregnancy is very precious, because of which they want to ensure that everything is okay and anxiety levels are high. In the evenings, if they cannot find the baby kicking, they panic and they run to the emergency rooms. So how can we have solutions that really allow for this care to be at the next level is what we are talking about. Home care really is here to stay. The question is this just a product? Is it a group of products? Is it a platform like Professor Hort spoke about? And how can AI, use all of this diverse information together in one place? And we triage the most sickest of patients is the most important piece from our standpoint. Such a tool is extremely beneficial, especially in low and middle income countries, where accessibility to skilled labor can be a challenge. And like we already, like there was already a presentation earlier, women in remote areas may have to walk a lot to actually get better access to care. We, of course, with such solutions, we're going to overcome the challenges of connectivity and better reduce cost of technology, hopefully using design thinking, which you just spoke about, Mr. Bhaskar. But that's exactly why we are here also as a company with GE Healthcare, to create a world where healthcare has no limits. So we look forward to this partnership and ensure that we're able to expand reach beyond where we are today. So thank you.
Thank you very much, Sharat. That's exactly where we want to go. I think it's only the first step, and you are on the right track. GE Healthcare is on the right track. You're working on intelligent ultrasound. So we'll probably in the near future have more and more about sonography and point of care and many, many other solutions. So thank you very much, Sharat, for joining us. And we are looking forward for new medical devices, new solutions. Thank you. Now let's move to the other presentation, to the other showcase. And it's a great pleasure for me to present now how do we deal with perinatal complications. And perinatal complications, the first part will be about preeclampsia. And the preeclampsia part will be presented by Tele Okanoho from the Revity Diagnostic Reproductive Health, previously was part of Perkin-Elmer, and Tele is going to present us their new solution for preeclampsia management, diagnosis and management. Tele?
Thank you, Mosh, and thank you for the opportunity to be here today to talk to you about these very, very important topics. So one of the big topics that also was mentioned by Anne Kihara is the access to care. So it has been in everyone's mind already today. And today we have already taken big steps to really advance the care and equity. And like Dr. Pai, he spent a while to discuss what kind of advances has already been done. We still have big barriers to overcome. And I see, like it was mentioned in the earlier presentation, that accessibility is one of the big barriers that we need to really overcome. And we have been thinking in Revity how to overcome this barrier, and I think that it is time to adapt and fit the solutions to the needs, to the purpose. And we need to bring the hospital to the patient. And we need to enable the access to affordable solutions, but also accessible solutions in the locations of the patient. And while I was listening what was said in earlier presentation, I invented this frame that access to care is actually access to patient. And COVID, the pandemic, it brought us a lot of different point of care solutions. But the challenge with these solutions has been that these solutions have been mainly qualitative. And if we really want to bring the care to the patient, the hospitals to the patient, we need to have quantitative solutions, quantitative data to really have the numerical values that actually have prognostic value also. And today, we have different solutions and innovations available like we hear today. And I think these solutions are really capable of fulfilling this need, and bringing those together, we can tailor the medical attention to the ones who need it the most. And with this approach, we're not only increasing accessibility, we're also using the scarce remote resources really wisely. One such solution we see here today is the innovation Revity has been working with. It is really to enable equitable data-driven care for all women. And it is a portable platform which is capable of analyzing and testing from whole blood, which is a huge advance itself. It can be brought to different locations, so it's not bound to any of the location. You can use it basically anywhere. And like it was mentioned in Stephen's presentation, this solution is at the moment in test in low-income settings. So we really went along the road that we tested in the very harsh conditions. And the first focus area, like Moshe mentioned, is preeclampsia. And the idea is that with this solution, we are introducing it first as a clinically efficient testing device for conditions that are threatening the outcomes of pregnancies, and really to impact the maternal mortality and morbidity. And we vision it to be a solution that enables access to care without binding it to any location, really bringing the hospital to the patient, but also, like it was mentioned and shown the paper from Moshe and the all of the group here, that it fits well as a part of the care ecosystem and remote monitoring and fitting well into the ecosystem, like I said. So thank you.
Thank you very much, Tele. So we covered now preeclampsia, one of the biggest killers in pregnancy complications. Hopefully we'll get it soon and we'll have it affordable to low and middle income countries. That's our direction. So please do something about it. Now we'll move to the other huge complication of pregnancy, diabetes in pregnancy, gestational diabetes. And one of the obstacles was, how do we diagnose gestational diabetes? The test up till now is to do an OGTT at a clinic at 24 to 28 weeks. In India, it can happen. My Indian friends explained to me that an Indian pregnant lady gets up at 4 a.m. in the morning. She has to prepare all the household for their day activities. She can start moving towards the clinic at around 8, 9 a.m. It will take her about an hour to reach the bus station, then another hour to travel, and then she'll reach the clinic at 10, 11 a.m. Can she come there fasting? No, there is no way. So we'll have to find a solution that is easy, that can be done at home. And that's where the home GTT is coming towards us, and the diagnostics company were very, very effective in producing it. So it's a great pleasure for me to present James Jackson and the diagnostic solution. James, the floor is yours.
Hi, everybody. I'm keeping my camera off because I'm in a hotel and the Wi-Fi is a bit unpredictable. I can see my slide is up now. Thank you, Moshe, for the opportunity to speak about GTT at home and our own ideas for digitizing the pregnancy pathway. I would like to say I started my career working in reproductive endocrinology in Cambridge in the Bourne Hall days. And the first diagnostic test I developed, my field is developing diagnostic tests, a bit like Teller, was for luteinizing hormone. And that was used in IVF. So today I'd like to introduce you to GTT at home. I'll take you through the product because I think this is all about the solutions today, which is a fantastic focus. The oral glucose tolerance test, or OGTT, is the most sensitive and specific test for diabetes. It's the only test recommended in many settings, particularly including screening for gestational diabetes. We all know that's called GDM. Traditionally, as Moshe was just saying, that it requires a visit to a clinic, which is an enormous problem, even in the UK. That's a difficult thing. A venous blood sample is taken in the clinic. The woman drinks a glucose drink, waits for 2 hours, then they take another blood sample, then the woman can go home. The samples are tested later in a lab, usually. There are some key problems with this. One is the resources needed to run the OGTT clinics, which obviously can't be finished until the last woman has been tested. Another, particularly in LMIC countries, but we find this in the UK as well, and the US, is patient access and women not turning up for their appointments. Also, compliance with fasting is an issue. But there's a very large problem which has been missed quite a bit by the obs and gynae community, which is the blood samples in OGTTs are very unstable and they can degrade between testing and when they're taken. So a woman with GDM could have lots of glucose in her blood sample when it's taken, but by the time it gets to the lab and is tested, it's normal. And in some places, more than 50% of GDM can be missed because of this. So with GTT at home, we've attempted to solve all of these problems in one go with a home use kit. The kit's been specifically designed to be easy to use. We've had 10 years of user testing throughout this period. From when the HCP books the test, our company manages everything. So instead of booking the woman for a test in a clinic, the test is booked in our secure web portal and we do the rest. And then we give the result back to the HCP at the end of the process. So to quickly take you through the kit, what you can see on the screen is the test device. In the kit, we have lancets, which we call prickers, the glucose drink, and you don't need anything else other than a receptacle to pour the drink into. To use the device, you start at the top. First thing you do is wash your hands. You pull off cover A. That hides a glucose sensor. You prick your finger with the first of the lancets, put a spot of blood on the device, it measures the glucose. You then take the drink, start a 2-hour timer, rest for 2 hours. When the timer beeps, it's ready for the next test. You cancel the timer, wash your hands again, remove cover B, which hides a second glucose sensor, and you create a blood spot and add a blood sample as before. There are icons and instructions on the device, and we also have a whole suite of patient support, and now it's being put into many different languages for use here in the UK and elsewhere. When you're finished, there's a data record at the bottom that holds all of the test data. That's scanned with a mobile phone app, which we're currently putting into different languages for use around the world. And all the device does is collect raw data. The data is scanned using the Apple Pay or Google Play technology, NFC, in every smartphone just about. And the data comes to us, we check everything has worked properly, and then we send the result back to the midwife. We're about to launch this in the UK. We'll soon be testing thousands of women each month in the NHS, allowing them to close their GTT clinics. Patients love it. There's some information on the screen from a recent pilot. And I'll just end by saying this takes me from working pre-pregnancy into working in the 4th trimester in my career in diagnostics. And thank you for your time. We also have a project for LMIC countries, which we'd be happy to talk about at some point to Moshe. Thank you.
Thank you very much, James. And another example, how life can be easier to manage pregnancy. That's exactly what we want. And that's exactly a product that UK is great, James, but the numbers are in different places. So please think about it. How do we do it there?
On the case.
Yeah, all right. I'm sure that you are on the case. Great. Now we'll move to the next presentation, again, dealing with GDM and diabetes. We prefer to take the niche in FemTech, pregnancy. But the device that you are going to hear in the next presentation is actually for general use, for everybody, not only for the female gender. Non-invasive continuous glucose monitoring. So it's there for gestational diabetes, it's there for diabetes. So the problems of how to measure glucose in the clinic are going to be solved. So the next speaker will be Giora Barzakai, and he is representing the Where2Be company. And Giora is going to give us everything he knows about non-invasive glucose monitoring. Giora?
Yeah, hi everybody. I'm very happy to take part in this roundtable. As Moshe mentioned, at Where2Be, we're developing this, a non-invasive glucose monitoring bracelet, which is based on our patented novel optobio sensor. And our primary focus is on measuring glucose. And by the way, we are measuring it from the bottom side of the wrist. This is how we place our sensor. And after measuring glucose, we found out that there is another field that we can contribute to, which is the GDM. And just to give a few words about GDM that I was not aware of, many people probably don't know about it. So GDM reflects a marked intolerance to glucose consumption during pregnancy. Now, we all spoke about the OGTT, which takes place on week 24 or 28 of the pregnancy, but it is way, way far in the pregnancy. So this is very concerning because once you have GDM, it doesn't affect only the current pregnancy because you have also long-standing effects that can affect both the mother and the fetus, because GDM is connected, according to studies, with adverse effects that can lead to non-communicable diseases. Studies show that for the mother, a previous diagnosis of gestational diabetes may carry a lifetime risk of progressing into type 2 diabetes of more than 60%. And for the offspring, the literature points to an increased risk of obesity during childhood and cardiovascular diseases in adulthood. Now let's talk about the numbers. The numbers of GDM are increasing year by year, and in low and middle income countries, as we are speaking here, they may get up to 30% of pregnant women, according to recent studies. Globally, including all the world, we are talking about 16%, meaning 1 out of 6 women will have GDM, and then the outcomes that we mentioned. So far, what we know about GDM, we don't know about how to diagnose it earlier. There are not very strong identified risk factors to determine you will have GDM and you will not have GDM. Diagnosis is very late during pregnancy, only on week 24, which is not optimal for the management of GDM. And the most alarming thing is the threatening consequences of high risk to develop non-communicable diseases. So this led us to think that a key to this situation would be an early identification of GDM in pregnant women. Such identification would allow timely introductions to delay or prevent diabetes onset. We believe that such detection of GDM will allow early stage interventions, providing opportunities for clinicians, private initiatives, and policymakers to durably impact and decrease NCDs. So accordingly, we have started a clinical study aimed at proving our assumption that collecting metabolic data and glucose level continuously during the early stages of pregnancy may enable us to detect early signs of GDM. So what we are doing, we are recruiting pregnant women around weeks 7 to 8 in pregnancy. We try to recruit women with high risk factors, but as I mentioned before, these factors are not very reliable. So we recruit the ladies, we then give them the With Me bracelet and ask them to wear it day and night from the very beginning of the recruitment till the week of the OGTT. Our hope is to be able to detect early signs of GDM during the first trimester. This way, we will be able to stop the progression of the GDM before it's too late. After spotting the signs, our goal is to continue the glucose monitoring and try to normalize the blood values, to normalize them. And then we can do it by nutrition, you can do it by awareness, you can do it by physical activities or any other intervention the doctors and clinicians may think about it. But our success would be to see that we are able to detect GDM early and maybe to enable to save both the mother and the offspring from developing GDM for the mother and then the non-communicable disease for the offspring and the mother after the pregnancy. So this is what we do. It's very inspiring for us, and we really hope that the outcome of this clinical study will be that our assumption is correct and we are able to detect GDM during the first trimester. Thank you very much.
Thank you. Thank you very much, Giora. Excellent presentation. In other words, we want to predict GDM. That's what we want to reach. And that's exactly what we were writing for the last 6 years in the FIGO guidelines. It's together with Hema and Anki Hara in our group of NCD pregnancy and NCD prevention. We want to predict and prevent pregnancy complications, and by doing it, we want to prevent post-pregnancy complications like type 2 diabetes, cardiovascular, etc. So hopefully the where to be device, the With Me device, will be a very, very good answer to prediction as well as to management of normal pregnancy, abnormal pregnancy, and then even abnormal type 2 diabetes. Thank you, Giora. And we'll move to the next presentation. And now we'll move to nutrition. Again, one of the major parts of pregnancy management, personalized nutrition. And who can be better than the leader of the Nestle Research Institute, Professor Eline van der Beek from Nestle. And Eline will give us all she knows about personalized nutrition. One size does not fit all. Eline, the floor is yours.
Thank you, Moshe. So nutrition is the core of what we like to investigate because we think there's a lot that actually can be solved by providing women, especially during pregnancy, with proper nutrition. But we also know that many women do not start pregnancy with a good health or with a good nutrition status. And as concerns in the past might have been around maternal undernutrition, these days more and more women in both high as well as in middle and low income countries enter pregnancy overweight or obese. All forms of malnutrition, including unbalanced diet, increase the risk of micronutrient deficiencies. And all of this is associated with a higher risk of adverse pregnancy outcomes, as well as long-term risks for both the mother and the child. So there's a reason to look critically at nutrition. But in addition, it's good to realize that pregnancy comes with additional nutrient demands that are quite specific and not easily met without making some serious adjustments in dietary intake. We've been involved in some recent studies showing that supplementation with a micronutrient blend, that in this case we topped up with myoinositol and probiotics, and that we started at least 6 months before conception and continued during pregnancy, that this intervention resulted in improved pregnancy outcomes. This so-called NIPPER study that was conducted in collaboration with the EpiGen Consortium in Singapore, New Zealand, and the UK showed a 57% reduction in the incidence of preterm birth. We also found a lower incidence of premature membrane rupture and postpartum hemorrhage. In addition, we observed a lower risk of obesity in the children that was associated with a lower incidence of fast growth after the mother had given birth to the child. We also found it reduced the time to pregnancy, but it did so in overweight women and not in obese women. And when we looked in more detail at how the supplementation improved nutrient status in the women, we found that there were clear differences between specific sites and also a large heterogeneity between women that had taken the supplement. So although nutrient supplementation may be an effective way to reduce the incidence of adverse outcomes, we need to ask ourselves the question, what is effective supplementation? So it's good maybe to make you aware that current recommendations like the recommended daily allowances or recommended daily intakes are actually designed to meet the nutrient demands of 97% of the population. And this is regardless of sex, life stage, environmental conditions. And thus for many people, these may be much higher than what is needed for individual cases. In addition, we know nutritional demands are strongly influenced by environmental conditions, risk factors, but also by your genes. And the example that I show here in panel 3 actually reflects what we know about vitamin B12 intake. So we know that there's multiple genetic factors as well as environmental factors that determine the bioavailability and the uptake of vitamin B12. And what you can actually see that this results in a very poor correlation between intake levels of vitamin B12 and plasma levels. And even with intakes far above the recommended daily allowance, this leaves almost 30% of the population with a relative deficiency despite high intake. So this really calls for a more personalized approach. And I'm sorry, the slides have been a bit, I think, changed compared to what I shared with you, but I hope you can still follow me through the 4 panels. So we've been involved in a large study conducted in Australia in collaboration with Professor Makridis that showed that supplementation with a high dose of omega-3 fatty acids reduced the incidence of early preterm birth. That was quite a nice outcome, but it did not affect late preterm birth incidence, which actually represents the majority of preterm births worldwide. Detailed analysis shows that the supplementation was effective in women that had a low omega-3 status at the start of the study, but it actually increased the incidence of preterm birth in women that already had an adequate DHA status at the start of the study. We subsequently developed an algorithm that allowed us to assign effective dose based on baseline DHA assessment. And this study is currently undergoing clinical trial testing in a follow-up study, again, that's conducted in Australia. But this is a great example of showing you that one size doesn't fit all, and that certainly more is not always better. So I think with these examples, I hope I shared with you that we really believe in the power of nutrition, but there's a clear need to develop products and tools that allow effective supplementation to improve outcomes for women during pregnancy and lactation, but of course also to meet nutrient demands during other life stages of the woman from birth until the end of life. And it's very clear that with this recommended daily allowances, we're only meeting the top of the iceberg in terms of demands. So I hope that with the efforts that we can do as a nutrition company, we can bring the nutrition offer that we can deliver closer to the real needs of the women that can benefit from this, for instance, to improve pregnancy outcomes. Thank you very much, José.
Thank you very much, Aline. Fantastic. And that exactly shows you how just showing 5 cases, 5 we want much more. We want much more input. We want much more devices. We want to put a huge effort in moving pregnancy management towards outside, towards point of care, home, and to make it much easier. Now I'll hand over to Hema Divakar because we still have one presentation that we couldn't present before. So Hema, please take it over now before we close.
Thank you, Moshe. I fondly remember in the committee for FIGO led by Professor Moshe Hood, Pregnancy and NCD Committee, the very issues that we were working and trying to turn our brains around how to make this happen in low middle income countries. It was all around nutrition, GDM, hyperglycemia, preeclampsia, sonography, all of this brilliant presentations. And Kiara and myself and Rishikesh Pai, of course, are waiting to see these innovations come to our part of the world for implementation. So thank you ever so much for this whole series of talks that we have just had. The question is India ready to leapfrog health and technology? Can they come together in this great country, proving to be the role model for the rest of South Asia and Africa and other LMICs? Well, we have a brilliant presenter for this, Dr. Madan Gopal, who has been driving innovations and building sustainable health systems for better health in India, working for the government as an integral part of Niti Aayog, which deals with transformational changes in the country and strengthening the health system reforms. We have the expert presented before you, ladies and gentlemen, Dr. Madan Gopal. Madan, please.
Thank you, Dr. Hema. Please accept my birthday greetings. It's your birthday today. God bless you.
Thank you.
Okay. One of the things which you have mentioned, I was listening to the presenter, and thanks that the technological glitch which has happened, first the host, they have removed me, they have, for re-admitting, it took more than half an hour. That means we should be having SOPs if we are using technological interventions. That's a lesson which I've learned today. That's another thing that I will be just focusing on how we leapfrog, how we are making leapfrogging in the technological innovations in the country. As you know that India is a country with a population of 1.4 billion. And every year we are having a cohort of around 3 million pregnant women. To provide services, as the government is committed to provide at least basic preventive antenatal services to these mothers. So we have to use technology. We have to use technological solutions for that. You look that in the financial sphere, we have a FemTech revolution in the country. And slowly we would be shortly having a digital revolution in the country. The National Digital Health Mission has been launched with the aim of creating an ID for the persons, because in the FinTech we have also created an ID, and that ID is linked to the bank accounts. As a result, the digital payments have been a reality now, and even a small denominations can also be done to digital payment. That's one thing. Second thing, in the health also we are moving in the same direction, and we are creating a digital ID. Right now, around 400 million digital IDs have been created for the people, and these digital IDs would be embedded into the records, patient health records, which will eventually become electronic health record, and this will be used for different service provisionings for the country. We are moving in the direction, and the mission is taking this forward. Apart from that, we are having a fast growing digital footprint in the world. India has witnessed a transformation in healthcare sector. We have around roughly around 700 million internet users in the country at the start of 2023. With this, it is a home for around roughly around 470 million social media users. Besides that, a total of 1.1 billion cellular phones are there. which is equivalent to 77% of the total population. These are only figures to say that how the internet penetration, smartphone ownership, and the government initiative that have created a fertile ground for innovation in the healthcare. This is aiding in many activities. In the benefit, the inclusion benefits which are there, they are linked to the numbers, the IDs. As a result, the inclusion benefits are directly going into beneficiary accounts. There are many innovations which are happening that such as Internet of Things, virtual healthcare, remote monitoring, artificial intelligence, big data analytics, blockchain, smartphone wearables, data exchange platforms, and remote data collection as well as remote monitoring. Besides that, we are having lot of innovations in the clinical decision support system. Apart from that, apart from the clinical decision support system, we are trying to build in the data-driven treatment decisions that will aid the clinical decision support system, and is patient-centric. Additionally, these advancements have paved way for more evidence-based approach, equipping healthcare professionals with knowledge and skills needed to support better healthcare delivery. These developments can usher an era of 4P medicines. 4P medicine means predictive, preventive, personalized, and participatory healthcare. With the digital transformation of healthcare holds as a digital transformation of the healthcare holds immense promise challenges. The following challenges we are trying to address the following challenges. The digital determinants of health, such as literacy of the information and communication technologies and access to equipment, broadband internet, becomes a critical for digital health. Not everyone in India has equal access to digital tools and internet. Efforts are being made to bridge this digital gap, and we are trying to ensure the marginalized communities benefits from the digital solutions. We are trying to ensure that the security and privacy of the data is also being addressed. We recently had this Data Security and Privacy Act, which has been enacted by the Parliament. The rules are being filled so that this aspect is also taken care. Since healthcare is a socio-cultural sensitive issue, in this digital solutions must be culturally sensitive to accommodate diverse healthcare needs. The application which works in one state, because each of the provinces in the country represents a big country in the western side. So we have to, and they are all culturally different. Whatever applications we are and the solutions which we are suggesting, the we are usually factoring the cultural sensitivity of that area to accommodate the diverse healthcare needs of that population, that regions across this. Furthermore, sustainability is a crucial in ensuring the long-term access to digital care. We are trying to see that how the digital technologies become an essential component and an enabler in the health system. As you have seen with the launch of this National Digital Health Mission, and we have been using the mother and child tracking software. It's almost a decade and a half now, but we are just building on whatever the infrastructure which we have made. We have all the essential ingredients for exponential growth for digital healthcare sector, including large population, a robust pharma, medical supply chain, smartphone users, and technical workforce. As the pace of digitalization, digital innovation accelerate, the opportunities in healthcare is also multiplying. The patient outcomes are improving. The footfalls in the private and the public sector, they are increasing, as well as we are trying to find more and more solutions to the technological innovation. We today stand at the cusp of digital revolution in healthcare. Now it is very crucial that the public and the private, they collaborate, share insights, and form partnerships. And this will continue to drive innovation in the field and chart path forward. With this G20 presidency, India has already shown and already collaborated with a lot many other similar thinking countries in reshaping and digitalizing healthcare innovations, ensuring that every individual has access to quality healthcare, and has launched several initiatives for digital empowerment. We see that how we can together envision and offer a hope for a healthier and more equitable. That means we are more or less at the cusp of leapfrogging into the innovation side of the healthcare, and digital is the solution. Use of technology is the solution for reaching this masses, and we are moving in the right direction. I will stop here. Thanks once again, Hemaji, for this opportunity, and the FEM team for this opportunity. Thank you very much.
Thank you, Madan Gopal. Over to you, Moshe. Thank you.
Thank you very much. That was very important, and we would like to stress the importance of the involvement of the governments. And the Indian government is doing it the right way, and hopefully we'll be able to collaborate at a later stage and to set up trials and clinical trials and other experiences that can be conducted in India. So thank you very much, Mr. Madan Gopal. That was excellent. So we came to the conclusion of this meeting, and I would like to share with you only the last comment. We'll be having the next FemDeep International Congress in Sorrento, May 23 to 25, 2024. It will be a unique experience. All the lectures that you heard here will be presented broadly there. We are going to push more and more the agenda of connecting the FemTech community to the medical community, together with the leaders of the FemTech community globally, like Renita Das, Karen Leshem, and others, ladies that are actually leading the FemTech community, and with us, the medical expert. And you see the names there that are representing the global associations coming from all over, FIGO, RCOG, SIGO, many FOGSI, and many others. So please join us there in Sorrento, 23 to 25 of May, 2024. And at this stage, I would like to thank you all, the speakers, the participants, for taking part in this, I would say, outstanding meeting, webinar. And I would like to send my gratitude, especially to my ambassador, to the PQE ambassador, to FemTech, Mrs. Nadia Procopio, and to the man who led all this initiative, Lodovico. Thank you very much. And of course, I would like to thank PQE for supplying all that we needed here to run this webinar. And we here in PQE are going to push forward the agenda of FemTech, women's health, and the connecting all the communities together. Thank you very much, and see you soon on our next webinar, on our next Congress in Sorrento. Thank you. Bye-bye.
Thank you. Namaskar.